people are going to get more familiar with you, and we're just going to let people start coming in. I'm going to do, I'm going to let you introduce yourself, and then I'm going to tell a little bitty story about the ER and how fitting it is that we're talking about this today. And hello, everybody coming in. Let me know that you're able to hear us okay. And hi, Donna and Janet, Rebecca, Grazia. Hi, guys. Can somebody give me a yes, you're good in the chat so I can make sure we are being heard? And hold on a moment. All good. Perfect. Thank you so much. Wonderful. Okay, we're going to get started. This topic, I'll tell you all in a moment why it's so fitting. But Dr. Allen, tell us a little bit about yourselves for those people who are new to you today. And thanks again for being with us.
Yeah, so my name is Dr. Allen Hopkins, and I've been doing emergency medicine for the last 20 plus years. I graduated from Loma Linda Emergency Medicine residency in 1999, and then I directly went to a level 1 trauma center and a level 1 pediatric trauma center. So I had pretty extensive experience with pediatric emergency medicine as well as adult, emergency medicine, and so, from seeing the gamut of all kinds of things, you would be amazed. Anything that you could possibly imagine that would come into the ER, it truly does. So it is an interesting thing.
When you say level 1, tell us about that, because we're talking about the ER today. So what are the levels to emergency?
Yeah, so a level 1 trauma center means that they can do everything they need to do. If you're in a car accident, for example, they can take you and they can do cardiac surgery on you. So they have all the essential specialties that they need. Level 2 trauma centers, they don't have the ability to do, to put you on maybe cardiac bypass or something like that. And then level 3, it goes down. So as you go down the levels, they're just less capable of having specialty services. And so most of your larger communities, the major cities, Houston, Dallas, Austin, we will have, 1 or 2 level 1 trauma centers. And so people will be routed to those trauma centers. So your gunshot victims, those type of people would go to a trauma center. And so in everyone's community, there is a designated trauma center. And this is so that when an ambulance comes and picks you up, or you pick up and you have a call, they know where to take you immediately. So, an ATV accident, out in the country, somebody falls off, they get a massive head injury, that's going to go to a level 1 trauma center. So they're going to fly in a helicopter and load you up and take you to a trauma center. So level 1 trauma center just means they have full capabilities of most, if not all, of the subspecialties. And they have to undergo additional certification, by federal agencies to keep that designation.
Okay, that makes sense. Okay, so welcome everybody. Real quick, I just want to tell you, and I'm going to go ahead and try to hit this live one more time out to Facebook and see if it works in just a moment. But as a reminder, any questions you guys have today, please put in the Q&A down on the bottom of the Zoom window. You can put them in the chat if you'd like, but it's easier for tracking purposes in the Q&A. And I was telling Dr. Allen before we started by text, I said how fitting this is, that we're talking about what happens when you end up in the ER and how to avoid it. And last night we had a emergency trip for my son, ended up with an appendectomy last night. And I promised a couple people, they said, please tell us, what was it like when you went in during COVID? I got a couple messages about that. And I just have to say kudos and a shout out to Erlanger Hospital here in Chattanooga for making it I can't say, the word pleasant, does that belong with ER? Because it was probably the most pleasant experience I've had in a hospital or doctor's office like thus far. We were in and out, triaged and scanned and blood work and surgery and all of that good stuff in less than 4.5 hours, I think it was. So he's doing well, he's at home, but I thought, wow, this was a great introduction to talking about the ER and how, I got to tell you, Dr. Allen, I was nervous about going in last night, a little bit nervous at the front end about whether or not they were going to require testing and what are the new rules as far as being in emergency rooms around COVID and what's expected of us as, people that are coming in to get the help that we need. So can you give a little bit of light to that? Is this a standard practice right now that you know of anyway, to test people for COVID when they're coming in for something that is clearly not related to that? And while you do that, I'm going to see if I can go live one more time while you're doing this.
Okay, yeah, sure. I'm sorry you had to go through that with your son. I know it's definitely a stressful thing. Having a child who undergoes surgery, it's always, stressful for that kind of thing. Mm-hmm. So for coronavirus, there are certain protocols that different hospitals have. Every hospital system is different. Some just require, coronavirus screening. So they'll obviously take your temperature, or they'll ask you, do you have any symptoms of coronavirus? And if you don't have any symptoms and there's no suspicion, they don't always test for you. Sometimes in the hospitals, if people are going to surgery, since that tends to be a much more invasive thing for the staff, they tend to do a rapid coronavirus test. So they'll do either rapid nasal swab, and that's what's done at most places, or a rapid antigen test. But they tend to do the PCR test, which is usually a nasal swab, if you have to undergo surgery. So it wouldn't be like a huge surprise to me if your son had to do a rapid PCR test just prior to surgery, so the surgical staff could know, what they're doing with, and particularly if they have to put him to sleep under anesthesia. That's the highest risk time for doctors and anesthesiologists and the nurses, is that time, because there's a lot of aerosolized virus if somebody truly does have coronavirus. Having said that, I transfer kids now to different places, and upon transfer, we sometimes will have to do the rapid PCR testing. So it's different for every hospital system. We were pretty strict about it like 2 months ago now, that the prevalence, at least in Austin, is very, very low. We're not doing it as much. We're doing more screening tests. Yeah, so it'll change over time as well.
Yeah. And I noticed that too. And I'm one to open dialogue and conversation with all medical doctors at any opportunity I can. So when they wheeled him back, we didn't have to go through any of it. In fact, the nurse said, I have to ask, has he been exposed to anyone with COVID symptoms, or, and I said, no, and she's like, okay. It went through the list, but no testing, no further inquiry, no questions about me, no hassles around not wearing the mask in there, and none of that. It was like I said, it was a very pleasant experience for someone like me who's anti all of it. But I will say, when I asked her, what have you guys been seeing here in the last year, with COVID and all that, she said, honestly, very little. She said, in fact, we have seen so few cases. She said, people try to keep it downtown where they do more of the investigative testing and questioning, but we've seen hardly anything out here. So I think, like you said, that's one of the reasons why they might have eased up a little bit on the process. So
yeah, and there are COVID specific hospitals too. In Austin, for example, they designated certain hospitals as COVID hospitals, and the reason for that is because they were able to isolate people much easier, take a whole wing of the hospital and, modify the recycling of the air and negative pressure rooms and stuff like that. So it's much easier for these hospital systems to designate, when they have multiple hospitals in the city, to designate a hospital to be a COVID hospital. So that's what they did here in Austin. They had multiple hospitals that were designated COVID hospitals, and they would take a wing of, each hospital and just make it, so that everything is set up, and everybody is specially trained, because it's a hassle to what they call don and doff. It's where you put on all your surgical gear, and then you have to remove all your surgical gear.
Okay. I gotcha. So maybe you can answer this question for me, because I thought this was pretty interesting, because I've been through multiple surgeries in my time, unfortunately. But they, at the end of when he was waking up, she handed him a little device, and you're going to know what this is, I'm sure. Do you need to talk? Yeah. Hi, Amy Beth. Is that Amy Beth out there?
No, it's my brother. I'm visiting my parents right now. So.
Oh, okay.
Yeah, I'm trying to tell him to turn it down.
Oh, turn it down. Okay. So anyway, they handed him a little device to blow into multiple times during the day so that he could cough. And they said this will help to avoid pneumonia after intubation, because he was intubated. What is that little device? And I've never seen that before. And I've been I've been intubated before. Is that a new protocol that they've put into place since COVID, do you think?
No, not so much since COVID. It's just an incentive spirometer. It's been around a long, long time. And, in order to help us avoid pneumonias and stuff like that, we have people take big, deep breaths. The issue really is one of pain, usually with an abdominal surgery or a chest surgery or broken ribs or anything like that. Really hurts to take a deep breath in. And so people will tend not to want to take deep breaths in. And so when they don't take a deep breath in, they can develop atelectasis, or collapsing of the small pulmonary arterioles, the alveoli. And then when that happens, then bacteria can sometimes overgrow there. So the best way is prevention. And so they'll have you do an incentive spirometer 10 times an hour, or whatever they can get a kid to do. But the idea is that, it's not going to hurt him at all. And it's going to help expand his lungs so that he doesn't run into trouble with pneumonia.
Okay, I like that word, incentive. So that's a good word, incentive, because we're going to give you this as incentive to continue to do the exercises, right? So let's jump right into this conversation. Like, let's give some people incentive to stay out of the ER, shall we? Something that's in their control. So what's the number? Can you give me, and I don't even know if it's top 3, top 5, like what are the top things that you see people coming into the ER for?
Well, that's very specific to the ER that you work at. Working at a trauma hospital, we would see a lot of trauma because everything is routed to us. That's trauma. Everything from the gunshots to the motor vehicle accidents to the guy that broke up with his girlfriend and he took magnets off the refrigerator and he stuck them up his penis, up the urethra. So all kinds of things will happen. Some of them a bit unusual.
Wow.
Anything that you can imagine. I've seen all kinds of crazy stuff. But if you're talking about prevention, I mean, the best thing that we can do is avoid chronic disease, because chronic disease puts you at risk for all kinds of complications. So a chronic disease example would be, for example, diabetes. When you have diabetes, you're much more highly at risk for cellulitis or infection of the skin. And so, sometimes diabetics, their nerves don't work very well because of the damage over the years. And what starts out as a little wound or a little irritation on your toes can end up being a really, really bad infection. And when you're diabetic, you may not have any pain initially when the infection is just sort of brewing. And then by the time you notice it, it could be pretty significant. And so I think diabetes is probably the number one, probably most common thing seen throughout the US. We see a ton of complications due to diabetes. And of course, diabetes ends up, oftentimes in losing your sight, losing your kidney function, having to go on dialysis, and so on. So we really do a terrible job of intercepting diabetes in this country, and I really wish we would do better, by getting involved early and checking some biomarkers that really make sense early on, and really working to try to reverse people that are going into that pre-diabetic or early diabetic state before they have to go on insulin. Once they go on insulin, they gain a bunch of weight. That's what insulin is. It's a pro-growth hormone. So when we give the insulin to keep the blood sugar down, we're actually encouraging people to pack on weight, and then their weight starts to go really, high. And then we start getting chronic inflammation, and we know that chronic inflammation is a bad thing too, because it leads to early stroke and heart attack. So diabetes is a big risk factor, and the whole metabolic syndrome X, being overweight with high cholesterol, high triglycerides, high blood pressure, and increased, waist to hip ratio, basically having a big belly. Those are the kind of things that end up in metabolic syndrome X, and it's called the deadly syndrome X because of the increased risk you have for all these things, whether they're infections or early strokes and heart attacks. So that's probably the main thing. Prevention is key when it comes to, just staying healthy. So that's why you got to sort of manage your weight. You got to check for chronic inflammation. If you have it, you have to work towards reversing it. And then, of course, you've got to intercept diabetes or control your diabetes the best you possibly can. That's probably the number one way to try to stay out of the ER. Obviously, appendicitis has happened, gallbladder disease happens, and so those are the two most common surgeries we do in the US. Is taking out your gallbladder is the number one surgery that we do. So people oftentimes get a gallbladder attack. Super common for women, particularly a woman who has had a bunch of kids. Hispanic women are very high risk. Usually you're in your 40s to 50s when it happens, but you can be much younger. But gallbladder disease is very, very common. My dad, had a gallbladder attack, just about killed him about 2 years ago. He got really, really sick from it. And so it is a problem.
Okay, so let's stay with the diabetes for just a second, because, let's go to psychology for just a second, because I'm sure while you're in the ER, you've got an opportunity to have conversations, right? How did your sore toe turn into, necrotizing tissue or whatever? Like, what's going on in the minds of people that come into the ER with things that are so far gone? I mean, not that you can get in their heads, completely, but what kind of conversations have you had to where people have just let it go and let it go and let it go, and then the only opportunity to get some help is to get to the ER, and by then there you are, right?
Yeah, well, people are scared. I mean, that's probably the number one thing, is they're scared. They don't want to have to come to the hospital. Coronavirus made that 10 times worse. I mean, our patient volumes dropped dramatically. All the appendicitis and the gallbladder disease and everything just disappeared. In fact, the volumes were down so significantly that most ER doctors across the nation, most of them that I know, have taken a 25% pay cut and have lost hours, so they can't put in as many hours. And so there's a massive shift in ER right now because of what coronavirus did. And it wasn't that it was coronavirus patients; it was there were no patients, and that sort of plays into the fear factor. There's a lot of fear around it. And even today, people are still put off coming in because of coronavirus. Okay, so pre-coronavirus, what was the problem? Well, it's just being afraid, knowing there's a problem, but not wanting to do anything about it. I remember this lady had a huge breast mass, big breast cancer, big fungating thing that was leaking blood everywhere. And she had it for a couple of years and just been growing. And her family had tried to take her to the doctor many times, and then she'd agree to go after being beaten down. And then they would drop her off at the front of the clinic, and then she would turn back around and walk out and say, no, I just can't do it, because she was just afraid of what it meant, and she was so sure this meant that she was going to die, and she just wanted to be home. And so there are people like that where things happen to them, and then they're just afraid. So I think fear is probably the number one thing. And of course, on the other side of that, we have people that are bit by an ant, and they have a little ant bite, and they come in taking an ambulance, coming in because of fear that they're going to die from the ant bite. So, I mean, there's we see the entire humanity. We see the super anxious, super fearful people. And then we see on the other end, the people that just, either they don't really care, or more likely they're afraid. Okay. And so they just won't come in.
Yeah. Or you've got people like in my ex-in-laws to be like, just pour some kerosene on it. I'm like, it's a wide open gaping hole. No, I'm not going to pour kerosene on that. We're going to go to the doctor for that. Right.
Yeah.
Yeah.
Well,
okay.
Early intervention is always better because it allows us to do less. And so less invasive, less problems, less chance for complications. Every treatment comes with a complication. Putting your son to sleep means that he's going to get an anesthetic, and who knows if he's got some sort of weird potential thing to the anesthesia. And so we don't like to have to be super invasive unless it's required. So, and even with the CAT scan, did your son have a CAT scan?
He did. Yeah. Yep. And they tested him, his creatinine levels before, they would do the dye, but it was hard for the specificities. Is that a word? Because the pain was significant over the whole entire right quadrant. Right. Yeah. But it was like, it's all here. And we're like, okay, gallbladder, pancreas, appendix, liver, colon, what's going on over there? Right. Yeah. So what threw them off, because they took him right back and did the pressure and all that on, and the rebound test and all that, what threw the doctors off was like, you ate barbecue at what time? 2:30? You ate barbecue today? I mean, like, you walked in here without screaming in pain, and you had lunch at 2:30. So yeah. They got thrown off by the fact that he wasn't an atypical coming in. This started on Friday. So we have Friday, Saturday, Sunday, Monday, Tuesday, 5 days of pain for a brewing, appendix problem. And he didn't even come in presenting as if he was in any dire straits, right? Just, So it threw them off, and they said, we have to do the dye so we can see everything, because we don't know. We aren't sure. That's what they told me when they took him back. Yeah. Well, the CAT scan sort of revolutionized the way that we are able to diagnose things. I remember I was working with an 80-year-old surgeon who's still practicing. And we were seeing a trauma patient who was a car accident. And, he was examining him, and I was examining him. I sent him to the scanner, and the surgeon was like, he's going to be fine. And I was like, well, let's just see, because he look, I might have some things. He had all kinds of problems. And the 80-year-old surgeon was like, those CTs, he was, man, back in the olden days, I would have figured it out. It would have taken me a couple of days, but I would have figured it out. Oh my gosh. Why not do the CT, man? So anyways, we do a lot of CT scans. We've gone away from them in recent years, particularly in kids, because we found that the cumulative doses of radiation can produce soft tissue cancers, 20 years down the road. Mm-hmm. So we used to sort of light everybody up, back in the day. Now we are really careful. We really ask ourselves, do we really need a CT scan or not? Mm-hmm. A lot of pediatric hospitals are moving towards ultrasound for appendicitis, which of course, no radiation. And if you see a big inflamed appendix, you can do that, but you have to have somebody who's really skilled and comfortable at doing tons of kids in order to do that modality. Yeah. So CT scans are, really good, particularly in your son's case where, the history is kind of confusing. It doesn't seem like it's straightforward, and it could be lots of different things. And the CT scan really is a three-dimensional reconstruction of the inside of the body. And so it really tells us where the inflammation is going on. And that can be a big clue to what the problem is, because we see these patterns. Just like we did with coronavirus, before we had any testing here, our CT scans would pick up a very specific pattern in the lungs that looked like coronavirus. And we would see it over and over again. And so they wrote a paper and they said, hey, these are the things we need to be looking for since we don't have tests.
And so we were able to find it based on these CT scans.
Okay, so let's flip the question upside down then and see if this is more fitting and easier to, kind of help people understand. The 5 things that they can prevent, like what are the things, like besides diabetes, right? Heart disease. What are you seeing people just being like, I'm fine, I'm just going to keep living this way? Like, give us some of those things. Heart disease, obviously, though, anything like that.
Yeah, well, I assume most people on here that are listening are women. I'm just making that assumption. I don't know, I'm just biased that way. Maybe not, maybe they're men. But, men who have a partner, studies have shown, will live 10 years longer than men who do not have a long-term partner. And the reason for that is that women are much more cautious and careful. And if they see something and they hear the man complain about something, they'll insist that he go in and get checked. And I think sort of that's the one thing I do notice, though, in practicing, is that if a guy, a guy can be pretty stubborn and pretty stupid, have chest pain, not want to come in and get checked, those kind of things. And so I think that, as a woman, it's such a great thing to do, is to be able to be on top of not only your own health, but on the health of your family, and to be able to say, hey, you're having this problem, you're going to go in and get checked. So you can encourage people to take action early. It doesn't have to be in the emergency department. It could just be going to their doctor, going to a cardiologist in this case. We talk a lot about, learning about the risk factors for having, stroke and heart attacks. And so by you guys being health coaches, you know that lipoprotein A, I talk about it all the time, is a huge risk factor that nobody knows about. And so particularly if you have a family where you have strokes and heart attacks in the family, like, everybody needs to get screened for this super small, super dense LDL particle, or low density lipoprotein particle. It's a cholesterol particle, but it's really sticky, and it tends to cause very accelerated heart disease, as well as disease of your cerebral arteries in your brain. And it also increases your risk for having a blood clot, like a pulmonary embolus or a stroke. So like, we know this is a risk factor, but nobody's talking about, nobody knows about it, but now you guys do. And then the other one's more common, right? No smoking. Of course, smoking is bad. If you smoke for 30 pack years, 30 years a pack a day, that's about equivalent to a person who has lipoprotein A. So that's the significance of lipoprotein A.
Wow.
So in lipoprotein A and smoking, and then of course, about just having really, really bad cholesterol. And it's mainly having really, really low good cholesterol. You really want to have the good cholesterol to be nice and high. And the way that we increase that is exercise, right? And so exercise is a really key thing, as well as omega-3s. They can actually increase your HDL, particularly your most important HDL. So I think there's some very common sense that, people sort of know about. But I would just encourage you guys, since you're all interested in health and you're here, is to, learn about lipoprotein A, find out if people in your family have it, and take action on it. If you find that out, you're going to watch them more carefully. They're going to go to a cardiologist even before they have symptoms, to make sure that everything's under control. Blood pressure is a huge problem for people. That's kind of one of the first things that we see. And you might see in a family member, you might notice their blood pressure kind of runs high. Maybe their doctors told them it's high. Nobody really pays attention to that, but that's a huge red flag and warning sign over time. So getting a blood pressure cuff, making sure they take their blood pressure, twice a day, and write it down, and make sure they keep their blood pressure right where their doctor wants it to be, is a good preventative thing. When your blood pressure gets super high, you can bust out an artery in the brain and have a subarachnoid hemorrhage. And, I've seen that so many times, I can't tell you.
Really?
Those tend to go to level 1 trauma centers too, because they need a neurosurgeon to go up and put a coil in their brain and try to get it to stop. So there's a lot of really cool advanced techniques they can do now with interventional radiologists, try to help people, but ideally you don't want to be in this position. So I think the number one preventive things for me are considering diabetes, and then the common sense things of, smoking, trying to do good exercise, and of course, eating is super important. That helps with, prevention of diabetes or reversing it if you eat the right food. So, and then blood pressure. Blood pressure is a huge thing that everybody, should have an idea what their blood pressure is, and is it good, or, does it need some work? Doesn't mean you need to go on medication. Just means that maybe you need to watch the salt in your diet. Maybe you need to lose some weight. I've had so many patients come off blood pressure medicine just by weight loss. So it is one of those things. And then of course, there's people genetically, they're just going to have high blood pressure. Everybody in the family has high blood pressure, and they have high blood pressure too. And they just let it go for 20 years. Those are the people that I see in the ER. They come in with their
Mm-hmm.
all kinds of problems related to that.
Okay, stay there for a second. So, one of the things that we try to talk about, and we're talking to, health coaches and the general public, but as health coaches, we try to say, even though it's genetic or there's a familial trait, doesn't mean that's your destiny, right?
Right. Yeah.
So is it true? So when you just said that about blood pressure, like if you just ignore it and let it go and you keep living in the same life and all of that stuff, is it a cumulative problem for blood pressure?
Yeah, it's it's a cumulative problem over time. Typically, somebody doesn't have a high blood pressure just one time, and then pain causes high blood pressure, right? Anxiety causes high blood pressure, those kind of things. But if a person has been told before, they've gone to their doctor and their blood pressure is high, they got to keep an eye on it, and it's something that doesn't kill you in a few months. It usually kills you over years. And so we tend to not pay much attention to it. Oh, my doc said it was high at some point. Well, it's been running high for 10 years now, and nobody ever did anything about it. And so it's a huge red flag for me if I see somebody who has high blood pressure. And the blood pressure parameters have changed over time too. 140/90 used to be something we would start to worry about. Now we start to worry about something called pre-hypertension, kind of like prediabetes,
Yeah.
And that's anything above 120/70. So we really like to keep the blood pressure less than 120/70, to be optimally healthy. So if we start seeing it creep up, again, it doesn't mean we need to be on a blood pressure pill, but we should be paying attention to it and checking it.
Okay. Can you cover those? Okay. So mine's usually really low. My blood pressure runs really low. I want to talk about that in a second, but mine's like 95/70 sometimes or something like that. And
Yeah.
I've had multiple times where I've had my blood pressure taken and the nurse wheels in the blood pressure cuff. She looks at it, she runs out, she brings another one in, she runs out, she brings another one. That's happened to me many times. So I've started to say, there's nothing wrong with your cuff. It's low before you even start to take it. But what's the concern with low blood pressure? Tell us about the numbers and what they mean, diastolic and systolic.
Yeah, so systolic is the top number and diastolic is the bottom number. And we like for most people to be somewhere between 90 systolic to 120 systolic. And it depends on the situation. If we have somebody like you, a skinny little girl, your blood pressure is 80/40, you have no symptoms, I'm not going to worry about you. But if you're somebody that just got hit by a car, I'm going to really worry about you that you have an internal injury because you have hypotension. And so the blood pressure is really relative to the body frame of the person. And also you have to make sure they're checking you with the right size cuff. So the problem with skinny people, the problem of getting a blood pressure check is the blood pressure cuff is often too big for your arm. And so what that will do is that will show us a falsely low blood pressure. So you need to have an appropriately sized blood pressure cuff put on your arm. It's the thing that goes right here on your arm, and it's really shouldn't be for you to actually be determining that. It really should be for the person taking your blood pressure should know that. But we do see that sometimes, especially with the younger nurses. I'll tell them, hey, can I see the blood pressure cuff? And they took it with a big blood pressure cuff. And I'm like, oh, it's not really 60/20. It's actually, much more normal blood pressure. I typically don't worry about low blood pressure in a person who looks like you, who's slender. Can I just say athletic build? I don't want to. Okay. All right. So
we've met in person.
Right. Okay. Yeah. So somebody who is your stature, I don't worry about, unless we're talking about certain scenarios where, we should be worried, gunshot wound or a car accident or, some type of thing.
Okay. That makes sense. Okay. Yeah, because again, and I've heard about certain things too that people with low blood pressure shouldn't use, like licorice root is one of the things that someone with high blood pressure shouldn't use because it brings down blood pressure. Have you found that to be accurate with herbs and things like that? Are there things you can do naturally to bring your blood pressure down?
I found out more important, the most important thing that I found out is just weight loss is the most consistent thing that I've seen over time work. Some of these other things could work for some people, but what I've found over time, the biggest mover is weight loss and then taking the salt, not completely out of the diet, but you need to lower the salt intake for people that have high blood pressure. Those two things tend to work the best. Genetically, some people are just pre-programmed to have high blood pressure. And these are the people that we typically will worry more about because no matter what they do, even weight loss and this and that, they still maintain really high pressures. Those are the people we have to put on medications. And if you're somebody who's on medicine, medicine's not a bad thing as long as, you're doing everything possible to get off the medicine. So in this case, it would be weight loss, watching your salt intake and plenty of people have come off blood pressure medicines because of doing that.
I gotcha. Okay, so let's go back to the kid for a second. As I told my students today when I was recapping the story, because he's my kid, you like to use our children as experience and examples. But when he told me his stomach was hurting as a parent, and I want to give some action steps for people today to, help them to calm down a little bit around these types of things. But as a parent, I started running through the list in my head. Like I said earlier, gallbladder's over here, appendix is over here. What did you eat? You went out of town. What's out of the normal for you? And can we trace that back? Constipation, what's going on? So what are some questions that people can ask themselves? First, I want to talk about the abdominal thing, because that seems to be a big thing. People get a stomach ache and all of a sudden they're like, I have stomach cancer. I've got to go to the hospital. I mean, I've heard that before. I'm like, okay, take a deep breath. You're probably going to eat something that was good for you, right? But then I also want to touch on fevers after that. So can you give us a little bit of a checklist for people if they're experiencing a symptom before they pack up the car and run off? Are there things they can investigate for themselves?
Yeah, I mean, I think the biggest thing that we can do is, treat some of this stuff at home. I actually treat my kids with Motrin and Tylenol if they have pain or fever or whatever. And then I, sort of see how they feel after that. Those medicines aren't enough to, hide an appendicitis or anything like that. But they treat fever really well. And so, I mean, that's sort of the number one thing I see at the children's hospital is fever. And, parents run their kids in there as soon as their child has a fever, And if they would have just given a Motrin Tylenol, the kid would just keep drinking and be super happy and playful, and they really wouldn't worry too much about it. Most fevers are viral anyway. They're just going to go away. Now, prolonged fever lasting for 3 days in kids in particular, oftentimes has to be investigated, particularly in young kids. Of course, we have a whole age breakdown. We have protocols based upon how old a person is on how aggressive we are with our workups. But in general, if we're just talking about parents, hey, if your kid looks great and he's running around, he has a fever, he doesn't necessarily need to, come in. But maybe he has a sore throat and a fever, and kids between 5 and 11 are much more likely to get strep throat. And we tend to treat strep throat, try to prevent, problems in the future with their heart valves, rheumatic heart disease. So in general, I think it's probably more appropriate to explain the different types of care you can seek. One is with your doctor, and that's somebody who you can get into, fairly easily, which is oftentimes hard to do. And then the second one, of course, urgent cares. And urgent cares are really a great resource for most people if they have sort of these little things where they think everything's probably okay, and they just want to get it checked out. And the reason why we try to get people to go to urgent cares is just simply cost for them. It's much less costly for them to go to an urgent care. It may cost maybe their insurance $200 with a $20 copay, as opposed to going to the emergency room getting a $2,000 bill with 20% co-insurance, where you're having to pay $400 or $500 or maybe a lot more. And so if you're a little bit concerned and you're not comfortable, and you feel like, oh, I think my kid's okay, then you could go to an urgent care. The problem is if you have somebody with abdominal pain, or you have an adult with pelvic pain or vaginal bleeding or anything like that, it's like the urgent cares do not have the capability of really figuring out what's going on, because they don't have the testing abilities. They can do very minimal testing. They can test your urine, they can test and see if you're pregnant, but they can't do a pelvic ultrasound. They can't do a CAT scan. They can't do some of these other things. So I always tell people, if you think everything's okay and things seem fine and you just want to get checked, an urgent care is a much better place to go. If you're concerned, particularly if you're really concerned, you have chest pain, trouble breathing, something like that, abdominal pain, don't go to an urgent care. You're just wasting your time. You're going to go there and they're just going to send you to the ER. And they're going to probably take care of you right away at the ER if you have those type of complaints, because the ER sees 90% of what we see as urgent care type stuff.
Okay. Yeah. We were turned away from the urgent care when we walked in with a finger cut. Not we, once again, hedge trimming cut. We walked in and they were like, yeah, no, we're not. No, you need to go on with that. It was really bad. So they just sent us right on our way.
Yeah. So if it's something that seems simple and fairly easy, and urgent care is a much better, fix. And I'm just amazed at how many people come to the ER when they have an urgent care issues, and really, because it'll be so much faster for them. Because when you come to a level 1 trauma center like mine, you're going to wait out in the waiting room forever to be seen if you have an urgent care issue. And of course, if you don't know what that is, you don't feel bad about taking your family member to the hospital, of course, and then the triage nurse will help figure that out. And oftentimes you go to the triage nurse and you kind of tell them, is this something we go to urgent care for? And they can say, yes, there happens to be one right down the street. And so it's like one of those things where I think it's really important to know what hospitals are in your area, what urgent cares are in your area, and what their capabilities are. Do you have a pediatric hospital to take care of your children? That's really good. They're much better at starting IVs on kids, much better at the whole calming them down and making sure they're comfortable. And, they really are attentive to to child's needs.
Yeah.
And so that's really great. And then is there a trauma center in town? Is there someplace that we, need to know about in case there's something major that happens? Somebody that we know there's a surgeon on staff 24 hours a day, 7 days a week, to take care of problems.
Right.
And so I think being familiar with how the medical system works is also really great for health coaches to know about, just understanding how your local medical system works and how you can tap in your resources to those particular places. You can really help your clients by helping them navigate the system because every system is different in each city.
Okay. So are there what are the levels of emergency? So if someone is, heading into the emergency room and they know they're in for a 5-hour wait and they're like, oh God, I really don't want to do this. Someone with a stomach ache and someone with a gunshot, obviously it's obvious the gunshot comes in first, right? I mean, depending on where it's at, I guess, but what are the levels of care? I've been left in a chair before with my kid before where I should have been rushed in first. And then I've been rushed in where I'm like, I think we've got a few minutes. So how do they determine the seriousness? How is that possible with so much going on?
Yeah, well, they usually base it on your vital signs and on the experience of the person triaging you. And so every system is different on how they do it. But, you could be a woman who has some abdominal pain and have a ruptured ectopic pregnancy. And if your blood pressure is low, that's the first thing the triage nurse should be thinking if you're in childbearing age is, why is her blood pressure really low and she's complaining of severe pain in her stomach? Could she have a ruptured ectopic? Because you can die with that within minutes. So you might get brought back at the same time as the gunshot wound to the chest, and because we can take care of multiple sick people at one time. I mean, I've intubated people in the hallway, put them on life support in the hallway while taking care of a gunshot wound. I've did a thoracotomy where we cut open the chest on a police officer in one room, and in the next room, took care of the guy that shot him with a gunshot, through his hand from the police department. And so we run from room to room, and the nurses, typically will pick up a critical patient at a time. So we have the ability to handle multiple critical people, especially at a level 1 trauma center.
Okay. So I want to lay out.
We have that all the time. We have multiple critical people all the time.
Yeah, I saw last night it was a busy emergency room, like busy meaning bustling around and stuff. But once they determined what was going on, like I said, they've had to flip the lights on to put us in the surgery area. We went through all these doors and it was just us. They were turning lights on and staff was coming in just for him. And I thought, I guess it was the after hours emergency doctors come in, they treat the patients on call and then they shut the place down again. I've never seen that happen before.
Yeah, it's probably actually a surgical team they called in. They probably probably just called in their backup surgical team or the surgical team that's on call. They come in with an anesthesiologist and a surgeon who most likely is a pediatric surgeon or has a lot of pediatric experience. And they're the ones that do the surgery. And then when it's done and he's recovered, then they go home.
Yeah. I mean, we were home, like I said, around midnight last night. I thought we were in for a hospital stay of a couple of days. So things have really changed when it comes to how things are taken. I mean, they took his appendix out of his belly button last night.
Yeah.
Yeah. So tell us about laparoscopic surgery and how that's changed, because he was trying to explain it, you're not going to have a big cut. We're going to do it here. That has been a huge progression in surgery.
Yeah. We've moved toward more robotic type surgery, where we can actually use tools and video cameras to actually go in and take out gallbladders. We can use that to take out appendixes, and it's revolutionized the way that those people are taken care of because they're able to go home much earlier. They don't have these big incisions with all the complications that can happen from that. The bowels tend not to slow down after surgery, particularly abdominal surgery. People will get an ileus where their bowels just stop moving, and so it used to be, well, you can't send them home until they've had a bowel movement, but now with this this less invasive surgery, we're able to go into the surgery fairly quickly and just let you go home. So it is much different. It's so much better for scarring too, by the way.
Yeah.
The women that wear bikinis, and they used to have this big long scar from getting their gallbladder taken out. And nowadays, it's hard to tell that a woman's had their gallbladder taken out at all because they use very small incisions. I think there's 4 of them, and they're very small. So it's really difficult to pick them up.
Yeah, yeah. I mean, I had a C-section, and you wouldn't even know it. You had no idea. And I mean, I've had the surgeries through the belly button, and you can't tell at all. So I mean, I was pretty surprised by that. We've got a couple comments I want to touch on here in the chat. One is by Grazia, and this is maybe a controversial topic here. And if you're not comfortable answering it, that's okay. But let us know. She said, unfortunately, I've seen the nasal swab has active nanoparticles. They're not the typical usual swabs. I don't understand why they have to go all the way deep to the nasal canal, scrubbing the, she's using big words, cribriform plate and/or ethmoid bone. Why a simple saliva test isn't sufficient? This is a good question, Tell us what's the difference in between the two? And if you can catch it by sneezing out in the air or coughing, why are we doing this type of testing? Do you know?
Well, I mean, they're doing the PCR testing is sort of billed as the most accurate testing. I mean, it's more accurate than antigen testing. But again, it all comes down to what your suspicion is and what the requirements of the particular entity you're dealing with. So an antigen test is probably great for if you're going to a concert or you want to go to a football camp and they ask your kid to spit into a swab and let them test for an antigen. If that makes them feel better, great. Your kid doesn't have it, he doesn't have any symptoms, and you're just sort of jumping through the hoops. That's antigen tests are really good for that. PCR testing is more when you're saying to yourself, okay, this person is sick. We need to determine whether or not it's coronavirus because we're going to give them some really cool stuff. We're going to give them intravenous monoclonal antibodies or something like that. It's really expensive, so we really want to make sure that we're going down the right path, and we need accuracy. And that's where the nasal PCR comes in. The methods for collecting it are different depending on the type of swabs. We tend to do, I've done both types of collections, and I found both to be equally accurate. So, on people that I thought had it, most common, really highly specific symptom is a loss of taste and smell. If you tell me you've had loss of taste and smell, and that's pretty much all you've had, your chance of having coronavirus is pretty high, That's what I found. That is the most specific thing. I've had a ton of people who had a little bit of runny nose, a little bit of body aches, and they just have a common cold virus, the rhinovirus. We work with something called BioFire, which looks at 20 different viruses and some atypical bacteria. So we're going to check you for the flu. At the same time, we're checking you for coronavirus and the common cold virus, which is also a coronavirus, and some other things too, human rhinovirus and so on. So there's a bunch of viruses out there that nobody really cares about because they don't really cause severe disease. And we now have testing platforms that we can pick up those too. And that's helpful because then that reassures a person, oh yeah, your symptoms are not coronavirus, they're actually this human rhinovirus. You've got the common cold. We had the common cold before corona, we still have the common cold. And in Austin, in the last 2 weeks, everybody that I've checked that's had any symptoms at all has had the common cold virus, the human rhinovirus or the common cold coronavirus. And so that's kind of, that's helpful because then you start to see in a community that we're really just seeing less of it.
Okay. So what are your thoughts about that? I want to know what you think about how all the flu and the common cold and all that disappeared when Corona came in. I think we touched on this in our last talk, but
yeah, I haven't seen any cases of the flu at all. And I just read that I think there were 1,380 cases or something like that of the flu nationwide. And we usually have, 100,000 cases or what. Just a couple of years ago, we had 61,000 dead from the flu. That was in 2017, 2018. According to the CDC website, we had over 61,000 people killed by the flu, 643 children under the age of 18. So now we fast forward to coronavirus, and they're acting like they want to, give every kid a coronavirus vaccine, which I think is foolish. And the reason why is because back then in 2017, 2018, out of 61,000 deaths, 600 plus were children. And with coronavirus, we've only had 287 deaths among children under the age of 18, but we've had 30 million cases. So with far more deaths, 560,000 plus deaths, and we've only had 287. So the point is, this is not a childhood disease. This is not something that we see kids at all get sick from. Yes, is there 1 in a million? Yes, there is. There's, 1 in a million can get really sick from this, but there's also a lot of sick kids that we're talking about. We're not talking about healthy kids. We're talking about all kids. And so there's plenty of diabetics, there's plenty of kids that have, congenital malformations. There's plenty of kids with lung disease that are much higher risk for coronavirus. So if I was a parent, I would not run out and get my kid a coronavirus vaccine, no matter how much pressure anybody put on me, if my kid was otherwise well and had a great immune system, because the statistics are really, really, really strong in your favor. In fact, if you really look into it, the statistics might be worse for you to give them a vaccination. They might have an adverse effect from a vaccine.
Mm-hmm.
Where they get paralyzed from the legs up, or they get encephalitis or something weird like that. These things happen. And I've seen them happen a couple times.
How does that happen? How does it happen? And maybe you know this and maybe you don't, but I know it's the question on a lot of people's minds is how does it happen that a vaccine that hasn't been thoroughly tested like we think they should be ends up in hospitals and being administered in parking lots and drive-throughs?
I don't know the answer to that.
Yeah.
It seems to me they would be more careful. I think that by the time they open up the drive-throughs for these things, they thought that it was a little bit less problematic. In other words, the allergic reaction risk was less. That's what I think.
Okay. So tell me this. So before we wrap up here, I want to know the top things that we can, or what would you suggest? And I think we touched on this when we were talking about the labs. Would you suggest, and I know it was like cholesterol panel, we talked about the thyroid and whatnot, but I want to talk about kids for just a second, because it seems like, we get into our adult years, maybe in our 20s, and we start thinking, shoot, I'm not 15 anymore. I'm not invincible. I am prone as I age for things happening to me. Are there labs that children should have? And if so, what age would those labs be at this point?
Yeah. Well, I can just tell you what I do with my own kids. I mean, that's the best thing. So first of all, if I have a kid who looks great, acts great, developing normally, gaining weight, he gets in the teenage years, they're gaining muscle, they're doing all the appropriate things, they're developing their secondary sexual characteristics that you would expect. I do nothing. I don't do any testing at all. Could they have cholesterol problems? You can, but what are you going to do differently? Hopefully you're feeding them healthy as it is, So my idea is that I don't do a lot of testing in kids. Now, once they become adults, then we start doing sort of the generalized screening exams that we see. Kids are far more likely to have normal everything compared to adults. We have a saying in emergency medicine is it's really hard to kill a kid. So like, even though we might make big mistakes as doctors with kids, they seem to recover from them just fine. They'll bounce back so much better than adults. We make a mistake with an adult, suffers some really traumatic thing, it's really hard for an adult, and the older they are, the harder it is. But the kids are the exact opposite. They're just like little pieces of plastic. They just mold right back together. So kids recover from surgery faster. You'll find that out pretty soon. And they're up, doing everything. So I don't really spend a lot of time worrying about labs for my own kids. There are some people out there really concerned about food allergies, because of behavioral issues. Maybe, there's autism, maybe there's developmental delay in some other area. And these are the kids that really need to get some intensive testing done by people that are a lot smarter than me, that really try to uncover maybe some of the toxins in the environment, maybe some unusual food allergy reactions. Maybe there's something really strange, like a red dye problem or something, something that you wouldn't otherwise know unless you went to somebody who had a lot of experience looking for that. So I'm probably not the person to ask about that, other than to say, if your kids are really, really healthy, make sure that you don't take all your concerns and worry and anxiety about health and put it onto them, because they're already healthy. Yeah. And they're the healthiest that they can be. Yeah, if they don't have any symptoms and they're otherwise doing well, I don't worry about it at all with my kids. Okay.
So adult, when you say adult age, so 20, 21 is when we start getting a baseline, and then if they're, as long as they're healthy, okay.
Yeah, the issue there is all ones on behavior. You want them to realize that the health is kind of like goes around with their wealth, right? So if money starts to be important to them, you got to make sure their health is important to them. It's more important than money. And so you start to enroll them in the idea of, now that they're kind of getting out on their own, they need to pay attention to this, and they need to invest in it. And at least once a year, get some baseline testing done. And at that point, you check your cholesterol levels, you check for, fasting insulin and the glucose and the A1C and some of those things. Then a regular CBC, which is a complete blood count, and a comprehensive metabolic panel. And if they'll do those things once a year, and if they're female, doing the thyroid testing with it's a good idea. But if they do that once a year, that's all they have to do. And if everything looks okay, they don't need to worry about it. But the hardest thing is with these young kids is getting them to think they're not invincible, because that's I mean, the truth is, I'm speaking as a 50-year-old guy. I mean, these kids that think they're invincible, and it's really hard to convince them that, they need to pay attention to this, because they'll be like, I feel great, and so on. So you really want to get them off on some good habits of paying attention to stuff, taking care of their health. And obviously, if they're super healthy, that's great. And trying to keep them away from bad habits that we all, know about.
Yeah, living more proactively instead of reactively, right?
That's right. And you
Yeah.
get them into that deal, and get them into where they, hopefully you've had them eating well, and they've moved on. They're still eating pretty good, and they're exercising, taking care of their bodies. And I have 3 boys. I try to enroll the idea of working out and getting strong, and and getting plenty of sleep. Sleep is like the number one thing that I worry about with these teenagers, because they just don't sleep.
Yeah, they don't. And I heard one time, and I find this to be true, actually, that there's something going on with a teenager circadian pattern where they naturally stay up later and they naturally sleep in later, and that this whole process of conventional education, getting them up at 5:45 in the morning to go in and learn, makes absolutely no sense. And it's one of the reasons we've seen an increase in attention issues. They're not even awake when they start learning, when they're supposed to be learning things.
Yeah.
And I mean, I think there's some truth to that. I've experienced it up here since, for the last 3 years of having a teenager in the house. It's like, it's 2 a.m. It's time for bed. I'm not tired. I'm like, oh my gosh, right?
Yeah. Well, something you'll notice if you start looking for it is that every, I would say, between a kid that I see that's between 25 and 35, maybe even between 21 and 35, I would say 80% of those kids are on anti-anxiety medicine. They're on antidepressants, or they're on ADD medicine.
Mm-hmm.
And I would say 8 out of 10 kids that I see come through the ER on one of those medicines or multiple medicines. And it is completely a disaster as far as I'm concerned, because it wasn't that way when I was that age. We have a major problem with anxiety. And you probably saw this thing that came out recently in the last day or two, blast all over the news. A third of COVID-19 patients have been diagnosed with neuropsychiatric disease, afterwards. And what they did is they went and they looked through the medical records of all these people that had coronavirus, and they were looking to see what sort of, problems that were addressed later, months down the road. Anxiety was number one, then depression. And so I'm just like, who isn't anxious with the news blasting this stuff 24/7 on how you're going to die? And I told you, I had that 20-year-old kid. He had no symptoms, came in for a coronavirus test. And back then we didn't get it back right away. It took a week to come back. So he came back in, called him back in with the result because it was positive, so I could answer questions. Told him it was positive. He fell to the ground, rolled around the ground. This is a 20-year-old kid, rolled around crying, screaming out, I'm going to die. I'm going to die. And I said, you have no symptoms. You're totally fine. In 2 days, 3 days, you can go back and be with people. There's nothing wrong with you. You're good. Now, so we have, I don't doubt that people that get coronavirus worry about dying, because we pound it into them 24 hours a day on the news.
Right.
That's all you hear about. But when I read that article, I thought, this is such a terrible misinformation. And the reason why it's misinformation is because the baseline number of people that have this at this age group is significant. And then plus, I mean, why would anybody be surprised if they had any of those symptoms, anxiety or depression? I mean, we've been freaking closed down. People have lost their jobs left and right. They have huge bills when they get out of the hospital, millions of dollars, because if you're in the hospital and you're really sick with coronavirus, you may be in there for months,
Yeah.
And so I just thought this is the dumbest study. But it's not so much the study was dumb as it was the way that the media is portraying it makes you think that if you get coronavirus, and again, most people that get coronavirus have minimal or no symptoms. So that's like the majority, but it makes them think that even if they get minimal or no symptoms, they're going to have a neuropsychiatric disease.
Right.
So which leads to what? More anxiety. So it's
right.
fear. And that's why you're going to see the pressure being put on kids to be vaccinated because of fear. It's not because of science, because if they were because of science, they would demand that every kid get the flu vaccine every year. And the flu vaccine we know is much safer. There's been 1.6 million billion doses, 1.6 billion doses of influenza given in the last decade. And we know that for every million doses of it given, we have a bad outcome. A Guillain-Barré, the ascending paralysis, or we have an encephalitis or something. It's something devastating. But there's people out there that have devastating problems from vaccines. It's just very rare. About 1 in a million is really what it comes out to. And so my thoughts are, this coronavirus, we don't have enough data yet to say that the benefits of vaccinating children outweigh the risk. I think there's enough data to say if you're above 65 and you have medical problems, you're higher risk. You're somebody who are not going to really worry so much about autoimmune disease later on, the things that we don't know about. But if you're somebody who's much younger, there's been less than 13,000 people killed from coronavirus under the age of 45. So if you're 45 and under, your risk is very low. Again, it sounds like a lot of people, but if you look at 30 million cases that we know about, and there's probably far more people infected than that. So my feeling about coronavirus is, for people that are worried, they should be wearing the right type of mask if they're going to wear a mask at all. That's an N95. That's the only one that really protects you. And they just need to stay away from people, wash their hands. And this thing's going to be over with pretty quick, in my estimation, because, no matter how much the media says, like, there's going to be no cases. And so there's, I don't know what they're going to do, because you've got a ton of people already have immunity to it. They already have antibodies and T cell immunity and plasma B cells. And we think, the scientists think, that it's probably going to persist for years. So if you had coronavirus, you probably don't need to worry about getting a vaccine because you're protected for years into the future. And some people suggest it could be a lifetime. We just don't know. But what we do know is that it's not a young person's disease. And if you're healthy and young, it's not the thing that's likely to kill you. Yeah. It now becomes equivalent to the flu. The flu is much more dangerous for children.
Yeah.
So.
Well, I'm glad you brought that up about anxiety, because, in having, very open conversations with teenagers and being in the house for a whole year with one that was homeschooled, and having a 20-year-old here as well, I have gotten kind of firsthand exposure to how much anxiety has risen in teenagers. I mean, it has gotten out of control. Yep. And they tell me, everybody's got social anxiety now. People get around each other at school and they don't know how to interact. And not, let's just be honest, like, high schoolers are just mean. Like, I remember those days. They could just be mean to each other, and so I say, this is what I always try to say, like, anxiety it's all about perception, really. What's going on around you and how are you perceiving the world to be? Do you feel safe in the world? Are you creating an environment around you that makes you fearful? Are you paying attention to things that increase that fear? How are you eating? How are you living? And sadly, like I told you, I think last fall, I tried to go to bat for our kids and continued to do that, like saying, can we just make some common sense decisions here for these children? Because what's coming down the road, this is last fall, what's coming down the road is much worse than what we're dealing with right now. And that is stress-related anxiety and panic disorders, depression, all of that.
Yeah, and it was already bad before, is my point. My point is moving to a digital world where all the kids are living their lives on social media and everybody looks like they're doing great when they're maybe not, and not having that face-to-face interaction and that, that touch between people it's a huge issue. And we've had it going on for a decade. So that's why or even more than that, but it's been very significant before coronavirus. Now it's 10 times worse for a lot of people because now you have the fear of this virus and the fear of each other, and now you can't touch anybody, and you can't, imagine try dating in this environment. It's so difficult because you can't even, a kid went to school and he was new to the district and he's in a mask all day, and he can't introduce himself to anybody. He can introduce himself, but he doesn't feel like he's actually seen. And that, creates such depression for kids that they're oftentimes have to be pulled out of school. So it's a really bad thing. I think we've done a great damage to our kids. I really wish we would have managed this in a more common sense way where we had people that are high risk protected and everybody else, just let them live their lives, particularly children. And again, I fear that they're going to force a vaccine on kids. And I just went and testified before the Health and Human Services Subcommittee for the Texas State Legislature, and just told them, my concern is the doctors do not have informed consent. So we don't have to tell you when you come in for a vaccine what the benefits and risks are for the vaccine. Can you believe that? In Texas, it's all on the person. So it's up to the parent to research it and figure out if they're going to have an objection to it. Otherwise, you come to the doc and he says, oh, time for your vaccine. Here it is. And I was fought by the Texas Medical Association, who went against me, and they said it's too much of a hassle for us. We don't have time to sit around and talk to patients about the risks and benefits of this stuff. Nor do we think it's appropriate to let them see what's in the vaccine, because we were advocating for them to actually list all the ingredients in the vaccine so the parents could, ask questions about the ingredients and so on. There's a great concern about it out there. And the doctor said, nope, we think that'll unnecessarily scare them. So they put out a huge email blast saying that I was trying to, well, not me personally, but the people who are testifying, we're trying to introduce scare tactics. It's not scare tactics at all. What we're trying to do is doctors to step up to the plate and give informed consent, because it was an informed consent bill. Look, I have no problem giving you a vaccine as long as you understand the risks and benefits of it. And you know me, I'm going to tell you, you probably don't need it if you have a kid, but if you're 70 years old and you have diabetes, like my dad does, I'm like, hey, Dad, you should get the vaccine. That's my opinion, because coronavirus has a very high chance of getting you. Even if I can do all the right things, you're the type of guy that would have a problem with it. And that's just the way it is for some people. So it has to be a discussion with informed consent. And right now in Texas, it's not. And so we're fighting for that, because we really want people to know what they're getting themselves into, and not for it to be a reflex. You should take it by your doctor. We want the doctors to actually put their brains on and think about it. Because they're not taught about this stuff in medical school, I promise you. This comes down from the big pharma, comes down, says vaccine schedules, this is what you do. And it's hard enough to learn the vaccine schedules because they're so complicated. They're like 72 different vaccines, right? So the only way they're educated is if people that are concerned about their kids start asking questions.
Right. And it doesn't that put everybody in such a crazy situation or position? Like, it's just kind of like food, nutrition and food and all of that. Doctors, they don't have that training or that time to go in and learn all of that. I mean, that's not part of your training, right? And parents don't go to school to learn science, to learn to read vaccine insertion. So here we have two situations where the parents trying to raise kids and do all of these things over here, and the doctor's trying to do like the battlefield medicine and all of this. And then right in the middle, we have a hole, right? Which a health coach fits into nicely. But I mean, seriously, we have a gap right here with the busy parent and the overwhelmed physician. So then we have I feel like we have the child just sitting there looking back and forth like a tennis match. Which one of you is going to protect me right now? Who's going to watch over me?
Yeah, this is where a health coach and a health advocate really is the person to step up and say, hey, let's think about this a little bit. How many kids have died from coronavirus versus the flu? In a single year, give me some idea. So I need some idea around, I'm debating and give my child a new technology, which we don't have a lot of data about, versus something that, we kind of know a lot about, but a lot of parents still don't choose to give. I mean, 60% of the US doesn't take a flu vaccine. So, so to me, I want to know what the difference between the numbers are. And your doctor doesn't know, I promise you, they do not know.
Yeah.
So my thing was, we got to force doctors to actually inform patients, which means they need to learn the statistics and learn what the risks truly are, not just reflexively give out vaccines.
Right.
Particularly to kids. I'm much more motivated about coronavirus vaccines for kids, because I just think it's such the wrong approach for us to go. And I mean, what if we find out in a year that these things called pathogenic priming, and we have a huge problem with people getting reinfected, that they get huge inflammatory responses, and we've got hundreds of thousands of people dead that have been vaccinated, and now we've put everybody at risk because we've involved all the children. And so what if there's infertility issues, which there's concerns, people have legitimate concerns about that, so now you've wiped out, a lot of people. And there's a lot of people paranoid about population control, with Bill Gates and all this vaccine stuff. And the happiest guy on TV was Bill Gates when this whole thing came out. He was gushing about vaccines. I turned to my wife and I was like, it's so weird. He's so happy about this. It's just so weird. I mean, this one it first came out when coronavirus pandemic, and he's talking about vaccines, and he just seems so happy for an otherwise very boring guy. He was really happy and animated on TV. And I was just like, that is so weird. So I don't know. There's a lot of people that have legitimate, I think, concern. And at the end of the day, we should be in charge of what we put into our own bodies, particularly the bodies of our kids. And I don't want a government entity telling me what I should give my kid. I want to research it. I want to look at the data myself, and then I want to make a decision based upon the current health of my child. And if my child is healthy, then. So the guys, I would say this, it was interesting because the people on the committee did ask me, they said, so doctor, so are you telling me that if I'm given a chemotherapeutic agent, that according to you, you should list all the ingredients of the chemotherapeutic agent before I decide to take it? And I said, no, that's not what I'm telling you. I'm telling you, these are two completely different things. One of them is somebody who has cancer, and they don't care if there's gasoline in it. I mean, they are desperate. This is the Hail Mary, Yeah, you give me we all know chemotherapy is terrible and it's toxic, and like that's a totally different scenario. I'm talking about an otherwise healthy child who does not have a disease, and you want to give that kid a vaccine, without really knowing the long-term consequences of it. It's totally different informed consent there. And so I think they heard that seemed to make sense to them. So
yeah, well, I
anyway,
appreciate you fighting for that. Yeah, I appreciate you doing that, because I mean, like, I have a friend, Michelle Stanford, she wrote a book called Informed Consent, and she's been out there like championing all of this, like, just really screaming from the top of her lungs, and she feels defeated on a daily basis. I don't know how she gets up and screams about it every day. Like, we deserve informed consent across the board for everything we're eating, putting on our skin, putting in our mouths, injecting into our bodies. What is so hard to see about this, right?
Yeah, they did everything they could to prevent the testimony. I was supposed to testify at 9 in the morning, and I didn't get on until midnight that night.
What?
Yeah, so I literally waited around all day long, all evening long, waited, sat there, listened to all this other junk, and then they finally ended up reconvening and calling, me. So it is something where I think that, and I told them this, I was like, there's a lot of doctors that think like I do. And I go, you're never going to hear from them because they're afraid of losing their jobs. They're afraid of what other, people might think of them. They're afraid of being canceled. I was like, but it's kind of bad. I'm just telling you, it's kind of bad that other people feel this way, and they do. And you guys have got to do something about it, because if not, you're going to go down a road that you are going to be really regretful of. We're a powerful country because we listen to both sides, and then people can make their judgments. So, but if you start censoring people and you start canceling them and you start firing them just because they take a position on something, that's when we turn into something other than the United States.
Yeah, I agree. So I have one question I don't want to forget to answer here, and then we'll let you go here. So Jamie said she's got a question here on iron infusion and gut health. If you have any knowledge about that, she got a first infusion and had a very strong adverse reaction that put her in the hospital.
Yeah.
Is there, how can that happen? She's kind of give a few details there, but I've heard of that as well. I've heard that IV infusions can make you sick. Is there an additive in those infusions that can be contraindicated?
Well, in that case, the iron itself can cause a pretty bad erosive gastritis. Yeah, so we'll see that sometimes. And I'm not so sure it's the same if somebody's taking oral iron versus IV iron. But I don't know a whole lot about iron infusions. I never gave an iron infusion. We would give oral iron all the time, particularly for vegetarians, because they always have low iron. And we did, notice that some people, particularly people who had peptic ulcer disease or gastroesophageal reflux, would have some complications of gastritis. So inflammation of the gastric. So I'm not sure what happened to her exactly, but I would have thought it certainly would have been due to something, whether it's the iron itself or one of the, preservatives.
Yeah. Thank you for that. Okay. So Rebecca and everybody's just saying, thank you for speaking up and fighting for patients. Healthcare needs more practitioners like you, and thank God for your courage and commitment to stand strong for our rights. And I have to say, I'm going to say this as a parting statement, is that, what you guys have had to go through and deal with and understand and experience, especially when you have conflicting emotions and feelings about what's happening, couldn't be easy. And I think that we've got a lot of people out there that are beating the hell out of the conventional medical system, which is one reason I'm going to be going about my experience last night and really giving kudos to the emergency room people. I love to give that, when it's due, but I just want to say that I appreciate that for anyone out there that wants to say that you guys, you take a beating and you keep going back to work every day and put yourselves in those stressful situations and deal with angry people and scared and fearful people, but you keep doing it. And there's, I just want to say kudos to you for that. And thank you for that.
Oh, thank you very much.
Yeah. And I hope never to end up in a trauma 1 emergency room, but I hope that I have someone like you there if I do. So we appreciate it. All right, you guys, heads up, just reminder, I'm going to be putting out a couple of the top labs that you can order from yourlabwork.com. Someone actually made a comment in here. I think it was Kathleen, that she ordered her, it looks like her from you guys, what was it? The advanced cardio panel and vitamin D. So that's awesome. So I'm going to give you guys some suggestions based on yourlabwork.com, and give you some preventative and proactive ways you guys to start taking control of your health. And just keeping in mind, we're talking to an ER doc here that's given us just some some facts about what's going out in the world. Nobody really knows what's going on in the world today, right? We're all responsible for the actions and the thoughts that we have, the things that we decide to do and how we react. So let's just remember that not everything is an emergency and most things are urgencies. I trained on this last Wednesday, and the replay will be shared today in your replay with Dr. Allen. If you have any questions at all, reach out to us. And of course, reach out to yourlabwork.com if you have questions about labs or anything like that, right? Any parting words, Dr. Allen?
No, I saw that Margaret made some comment about Del Bigtree. So Del Bigtree he's kind of a really interesting guy. I didn't know him at all, but I got a chance to become good friends with him, just sitting all day with him in the cafeteria waiting to testify, and learned a ton about his life and about what he came from, and all the things that he's been through. He's a super interesting guy. So if you haven't had the chance to watch his show, I think it's called The High Wire.
It is.
You should watch it. I mean, he really is a dedicated person who really believes in giving people all the information. And he'll readily admit when he makes a mistake or brings something that he may later have to retract. And he actually prides himself on that. And I think that's what we need. We just need the information so we can decide for ourselves. I'm totally for choice. I just want people to have a choice and not just be tricked into doing something or have something shoved down their throats.
Right.
And so that's what I would encourage everybody to do, is just, try to find those type of people that will give them some good information so they can use that as they consider what they're going to have to do in the future.
Yeah. And I'll share that link for the High Wire. I've been following him since last year. He had me so worked up at one point. I had to take a break from listening to him because he's so powerful with his fact. Oh my gosh. I'm like, I felt stressed out and anxious at one point. Like, I need a break from all of this.
He's got a really deep voice.
Yeah. He's awesome.
We have a fundraiser for him going on in 2 days, actually.
Oh, so really? In Austin?
Yeah, it'll be interesting. Mm-hmm. Yeah.
Are you guys going live on Facebook or anything?
I don't think so, because it's a group that does not want to be published.
I gotcha.
They're like there's some really powerful people that are really trying to push back on this.
Yeah.
And we're trying to get, people like Del to be able to bring the information out to people, because what he does is it's really good. He's good at what he does. He knows how to connect with people.
Awesome. All right. Just like you. Thank you so much, Dr. Allen. We appreciate you.
Okay.
I'll share all the links in the replay, guys. And all right, we'll see you again next time. Thanks so much.
Thanks. All right. Bye.